All right, well, thank you for joining me. This is Augie Galindo, one of the founding partners of Testosterone Centers of Texas. And this video will be a condensed version of basically all the information that I cover in the longer series about testosterone replacement therapy and its introduction. So at this point, we're going to assume that you've gone through the point of talking over your symptoms with a provider. This is really exactly what you would see if you were sitting across from me during a new patient consultation. So we're going to make some assumptions here that numbers are low and that we're talking about the nuts and bolts of how we approach therapy, how you compare your numbers to normal, the different options of testosterone replacement therapy, and then of course the balance or the assessment of risks and benefits. So we're going to dive right in here and start talking about testosterone levels first. Now, normal testosterone levels are between 350 and 1200. So obviously that's a big, wide range. But if you're somewhere past puberty and you're under 80 years old, I would say, roughly you should be somewhere in this range. Now, keep in mind, when testosterone levels are produced, or when testosterone rather is produced naturally, levels should spike and cause puberty. They should peak in your 20s. And then at around age 30, you should start losing 1% per year. So if you just take a simple mathematic approach to that and say that you have a number that's modest and say 750 at age 30, and you only subtract 1% of production per year, you should not reach these treatable ranges until your late 70s or 80s. It should take that long for your testosterone levels to go down. So the fact that we have men in their 60s, 50s, 40s, and even 30s dealing with low testosterone levels is a problem. This is something that is not normal. It's something that has only happened fairly recently. We've shown through studies that even men just 20, 30 years ago had testosterone levels that were 22% higher than what we're dealing with now. So this is where testosterone replacement therapy comes in. Now, when we replace testosterone, understand that I want to keep these levels a little bit better than just the bottom end of normal, because typically we're dealing with younger men who should be higher up in the range. Now, that means that I want to see your levels between 500 and roughly 1,000 or so. So this becomes our new normal, if you will. Now, the reason we cap this off, the reason we don't want to be in the bottom end of normal is because you have symptoms here that tend to worsen the further you go down, even when you're in the low levels of normal. We don't want it too high because this is where you start to invite more risk. And the higher you go, the worse those risks get. For somebody who's abusing testosterone, people often think of testosterone and just think of steroid abuse or roid rage or those sorts of things. The people who are abusing testosterone are using doses that are sometimes 10 or 15 times higher than what we would use for replacement purposes. So this is where we want to stay. This is a range where we are both healthy and happy. We're avoiding symptoms, we're avoiding excess side effects. But this is only part of the picture. If we look also into the difference between total and free testosterone, what we're going to notice is that if we count up every single molecule of testosterone in the bloodstream, that's what your total testosterone represents. If I look more closely, then what I'm going to see is that there are certain molecules of testosterone that are bound to protein, and then there are some that are free. So we have albumin soaking up 68% of your testosterone. We have sex hormone binding globulin soaking up another 30%. So together, 98% of everything that you have is locked away in proteins. They're just hitching a ride through the bloodstream, not really doing any work. So it takes free testosterone molecules to be able to migrate out of the blood vessels and through the tissue and out into the cells. And this is where testosterone does its work. It's actually commanding cellular activity. So if this isn't happening, then you're going to end up suffering some issues with testosterone deficiency symptoms. Now, keeping both of them normal is important, so we need to know what normal free levels are. Normal free testosterone levels are between 9 and 30. We utilize your calculated free testosterone because the studies show that that's the most accurate way to assess your free testosterone. So this number somewhat eclipses this number in importance. When I'm replacing testosterone, I want to see this number stay at roughly 15 or better. So that gives you an idea of what we're shooting for. Now, for our discussion here, we're assuming we're low. So if your numbers are low and I want to push those up into the normal range, And what I'm going to need to do is figure out what different methods I have available. Essentially, there are 3 different types of methods to do this. You have topicals, which are in a cream, gel, or patch. You have pellets, and then you have injections. We predominantly use injections for therapy, and we believe that's the best way to manage TRT. We occasionally will use topicals. That's typically for men whose schedules just simply don't allow for weekly injections. And then, of course, we recommend against pellet therapy. So let me quickly cover some pros and cons to each approach. For topicals, you are not tethered to the clinic as you would be with weekly injections. They can be more simple from that regard, but they do come with their cons as well. They're very expensive. The topical testosterone preparations, if you're buying the name brand, those are going to cost somewhere between $300 and $500 every month, on top of the cost that you would need to put out for the management of your therapy as well. So keep in mind that it's something you have to do every single day. You might not have to come to the clinic every week for an injection, but you have to remember to slather on this wonderful smelling gel every single day. Most men are not great about doing something every single day that they don't have to do. So we've seen a lot of non-compliance with topical therapy. That means that even if you're doing everything right, though, you still tend to have this response that's in the lower register of normal. So up to 40% of men don't absorb enough testosterone to make a difference. This means that this becomes a less effective therapy, and you get all the same side effects, but you often don't get the same benefit that you would if you're on injections. For pellets, pellets are very highly publicized and advertised. They claim to be bioidentical and natural and last for 6 months. Honestly, if testosterone pellets delivered on all their promises, they would be the best form of testosterone replacement therapy. We recommend against them. We do not use them for a number of reasons. Again, like with topicals, you're not tethered to the clinic as much. But keep in mind, this is not an FDA-approved method of testosterone replacement. They claim to be natural because where our testosterone that's made by a name brand pharmaceutical company that's very well recognized and respected, their medication starts in a lab and finishes in a lab. The pellets start with a plant-based sterol. So yes, that is a plant-based source, but it's finished in a lab. It still has to be manipulated so that it can be used in a pharmaceutical-grade product. Make it into a powder. That powder is shipped off to a compounding pharmacy. They use whichever ones are available, so your end product is only as good as the compounding pharmacy that made it. They will put up to 12 pellets in men all at one time, and all of those pellets start dissolving at the same rate. So therein lies the biggest issue with testosterone by pellet therapy. They don't have a 1-month pellet and a 2-month pellet and a 3-month pellet. They have 12 pellets all dissolving at the same rate, which means your levels go above normal typically for the first month and then plummet like a rock over the next 3 to 4. So they don't last the full 6 months that they claim. You end up low for the latter half of your therapy. You're too high in the beginning, inviting a lot of risk and side effects that aren't being monitored because you're not going to see a provider going into the clinic for blood work typically. Again, they're not FDA approved, they are expensive, and it requires a minor surgical procedure to implant these into your skin. So if all the promises were there, they'd be great. Unfortunately, they're just not meeting the promises. And finally, to speak to the bioidentical myth, understand that there is no bioidentical testosterone, whether it's by pellet, by gel, or by injection. What you're getting is biomimetic testosterone, and the difference may be slight, but it is important. It's not exactly like what your body makes. It will be recognized by your brain as such. Your body will react to it just like it does natural testosterone, but it, at the molecular level, is slightly different than natural testosterone, whether it's in the gel, pellet, or injection form. So that leaves us with injections. With injections, I can take a low number and overnight make that better. So keep in mind that when testosterone replacement therapy is done right, I'm not waiting on your levels to slowly creep into normal. What I'm waiting for is for this to happen, for testosterone to command its changes at the cellular level. So what happens with that first injection is testosterone levels start to increase. They peak at about 48 hours in, and by day 8, half of that medicine is gone. This is the half-life of the medication, and I can't change this. Now, some people try to push it, which means they might go to 10 days, and they end up having to give a bigger dose, exposing to more risk here, and hope to land at a good spot here. Some go to 14, And then that means that you're giving an even bigger dose, going higher above normal, and almost inevitably you're going to end up going lower than you want to be at day 14. Anything past that, again, you're getting the same picture. Much higher doses, more risk, less maintenance inside that mid-normal range that we're shooting for. So rather than fighting this 8-day half-life, I work within it. On day 7, we give another injection and we restart the process. So it goes up, it starts to come down a bit, we give more testosterone in the next injection, and so on and so forth. So there is movement, but it's not that huge roller coaster effect that you get over the course of 3 or 4 months with pellets. It's movement in a very normal, mid-normal, narrow range. So in this range, again, we're both healthy and happy. We get the benefits of testosterone replacement therapy, the androgenic effects as opposed to a lot of the anabolic bodybuilding, muscle bulking, and the muscle bulking effects that people get when they're abusing steroids. You do get some muscular benefit for sure, but in this range, again, you're both healthy and happy. So if this is the goal, then what's the cost? What is happening with testosterone replacement that we need to be careful with? Well, as with any medical intervention, testosterone does have side effects. So being able to recognize and manage those is extremely important to do testosterone replacement therapy right. The 2 most common issues that we deal with are increases in your estradiol, or E2, or an estrogen essentially, and then also increases in your red blood cell count. Now we actually look at your hematocrit, and I'll talk about that in a bit. But these 2 things are the most common issues that we run into with testosterone replacement therapy. Now, you are supposed to, as a man, have estrogen. You can't have 0. You have problems with osteoporosis or mood stabilization and or sexual function. So we can't 0 this out. But there is an enzyme called aromatase that takes testosterone and converts it into estradiol. When we raise your testosterone levels, sometimes your estradiol levels get too high. And if it's too high, then we run into issues with mood swings, hot flashes, fluid retention, and even gynecomastia, or breast development. So to maintain this number in normal ranges, we use anastrozole, or Arimidex, and it blocks the activity of aromatase just long enough to keep this normal. We don't want it at 0. We want it kind of like here in that mid-normal range. Now, red blood cells. Red blood cells carry hemoglobin. Hemoglobin carries oxygen. So, of course, we need the ability to carry oxygen to our tissues. The red blood cells are made by your bone marrow. They're made from iron. What testosterone does is it somewhat deregulates iron absorption. So now you have more iron available to the bloodstream and to the bone marrow. And so when bone marrow sees those stores go up, it starts making more red blood cells. That's good only to a certain point. That means you are carrying more oxygen, so that can mean that you're essentially breathing more efficiently. But what happens is if I take your blood sample and I put it into a tube, and then I put that tube into a centrifuge and I spin it around, the solid red blood cells sink to the bottom, and the fluid plasma floats to the top. Typically, your blood is made up of about 50% or less of red blood cells. Now, I want to stay here. I want that number to stay under 50%. So if these numbers start to creep up, that means your blood's actually getting thicker. Now, thick blood means it's a little bit harder for the heart to push. That can mean minor things like a headache, but it could potentially mean increases in your blood pressure. If it gets way out of hand, numbers over 60 and there for a long time, then you can look at things like spleen enlargement and blood clots. So it does need to be managed. And really the number I'm looking at is called your hematocrit, or your HCT. And that's basically that percentage representation of how much of your blood is solid red blood cells. So we monitor this carefully throughout treatment. Typically, we intervene in this by having you donate blood or through dose reduction. Both of those things work to keep this normal. Testosterone replacement also causes increases in DHT sometimes. So dihydrotestosterone does a few things. One of the things it does is it does influence the sebaceous glands of the skin, or the oil-producing glands, so your skin can become somewhat more oily. That extra oil can contribute to the trapping of dirt and bacteria and pores, and other issues with DHT can cause acne. In this range, we really don't see a lot of that. Almost always we can manage any acne associated with DHT increases with over-the-counter measures. DHT does also influence the size of your prostate. So often men with a low testosterone level have a low PSA because their testosterone level is low, their DHT level is low, there's less stimulation on the prostate, and so it's producing less prostate-specific antigen, or PSA. So when we normalize your testosterone levels, we could potentially normalize the size of your prostate. That means it may grow to an average or normal size. That does not mean it's getting bigger and bigger and bigger. It's just going from small to average. So this is not necessarily an issue at all. It may cause a small increase in your PSA. Your PSA was a tumor marker really made to look for prostate cancer. So it does go up with prostate cancer, but it also goes up with infection, with inflammation, with trauma to the prostate. Even riding on a cycle with a saddle for too long could cause issues and rises in your PSA. So this is something to be watched carefully. We want to make sure it stays not only normal, but stable. It's typically, for most men, normal from 0 to 4.0. So again, we want to see it normal at the start of therapy, normal throughout therapy. We worry about your PSA because of this one very rare issue. If there's an undiagnosed cancer in this prostate before therapy, it will grow more aggressively in the face of more testosterone. Now, while this almost never happens, we do watch for it like a hawk. We watch your PSA levels, we watch your urinary habits to make sure that there are no signs of obstruction or growth of the prostate to the point where we worry about there being a prostate cancer or a problem with your prostate. So again, one of those things that we watch for very carefully. Now, this entire process is controlled by the brain when testosterone is produced naturally. The hypothalamus, think of it as the thermostat, setting the temperature for all those hormonal processes. And in relation to testosterone production, the hypothalamus communicates with the pituitary gland by means of a single hormone called gonadotropin-releasing hormone. The gonadotropins that it tells it to release are LH, luteinizing hormone, and FSH, follicular stimulating hormone. So these two hormones tell the testes to produce testosterone and sperm. So these are the two jobs of the factories that are the testes. If everything's working right, then testosterone and converted estradiol are sensed by the hypothalamus, and that will determine how much or how little GnRH is produced. So this is called a negative feedback loop. If your testosterone or estradiol levels go up, then your brain says, I've got plenty, then we're going to reduce the activity of the factories. If there's not enough, then it should increase all of those. So this means that when we come from outside of the body, we put testosterone in, again, your brain's going to recognize it and react to it as it does normal testosterone. So it's going to reduce stimulation to the pituitary gland, which will reduce stimulation to the testes by reducing LH and FSH, and they're going to have less natural testosterone and sperm production. So if your daily pattern looks something like this, where you're higher in the morning and lower in the afternoons, when you're on replacement therapy, your numbers are suppressed because your brain's recognizing that you have plenty of testosterone. We're keeping your numbers normal through medication, but understand that this is suppression because this is replacement therapy. I'm not augmenting what your body makes. I'm replacing what your body makes. Now, that can cause some changes in the factories that are the testes. If they have less stimulation, they can change in consistency and or size. We can mitigate that issue by using another medication called HCG that to your body looks just like LH. This is not human growth hormone, this is human chorionic gonadotropin. And its role in this type of therapy is simply to maintain testicular activity, maintain volume, and you will see some maintenance of testosterone production. Not enough to make a huge impact. The only downside to using HCG is we tend to have to be a little more aggressive with the management of your estradiol because it can bump that up a little bit. But if you have low testosterone, you have one of three things going on. Either the testes are getting the normal amount of stimulation from the pituitary gland and they're just not responding, or perhaps the hypothalamus and pituitary gland are falling asleep on the job, or a mixture of the two. So if there's a testicular problem, that's primary hypogonadism. If there's a pituitary or hypothalamic issue, then that's secondary. Often we see kind of this mixed picture. But at any rate, these are the things that we look for to maintain testosterone levels in the normal range with safety. Our goals of therapy are to improve your quality of life while maintaining your safety. We never sacrifice your overall health just to make testosterone levels better. So in a nutshell, this is our approach to testosterone replacement therapy. If you have any questions or there's anything else I can answer for you, again, just throw something down in the comments and I will try to do my best to answer those. If you have anything else you'd like to talk about, you're welcome to contact me through the website. And I hope you've had the answers you've been searching for, and thank you very much for watching.